So I am Dr. Zan Nowakowski, for anybody who does not know me. I wear a lot of different hats. I am a professor at Florida State University of College of Medicine. I am a medical sociologist and public health program evaluator. I am 37, living with CF in Orlando, Florida. I'm a 10%er. I've got rare mutations, so I don't qualify for modulators. I am an ethnic minority. My heritage and lineage are mixed Creek, Germanic, and Arab, and my father is Polish. My biological father was Greek. I am proudly bisexual and agender, so I do a lot of education in our communities in Florida about what it means to show up for queer, trans, and intersex people in healthcare. I also hired our first openly intersex staff member at FSU College of Medicine. My pronouns are they, them, and theirs. I encourage everyone, if you would like to display your pronouns with your name, you have the power. You can use the participants feature in Zoom to edit that. Or you can put them in the chat if you would like to share that information with folks. So we'll talk a little bit about the preferred forms of address and some other ways that clinicians can affirm our experiences as members of queer, trans, and intersex community, but also just as unique people living with CF. So what I thought I would do today as a companion presentation to what you will be hearing from our wonderful collaborating authors, Eliza Callard and Katie Lawless, about the chapter itself, which I've been furiously drafting for the last couple of months. I thought that I would share with you some of the clinical education that I do with different clinicians who are practicing with diverse audiences and also specifically people with CF, to kind of give a flavor for how, when you have limited time, to open up opportunities for people to get excited about providing inclusive care. I give a unit, and I'm going to share my screen at this point, and give a unit every year, certainly at a minimum with our medical school, but also with different audiences, I'll give kind of modified versions of this. So let me put it in presentation mode here, just a minute. Right. My subtitles are off, so Zoom is not going to crash. Very good. All right, time for slideshow. So what I'm doing here with this content is usually working with people who are very new to clinical education. I've also used a modified version of this with people who are a little more senior, so residents or fellows, or even specialists who want specialized training. But really kind of taking people through the basics of providing inclusive care. This unit focuses on sex and gender diversity, but it also weaves in a lot of content about sexuality and other aspects of lived experience that really shape what we want and need out of healthcare. This is broadly based. We're very focused on primary care at the College of Medicine, but I always tailor the examples I give with this presentation to the specific care context as well as the audience. And I weave in elements of my own lived experience that are relevant, as well as elements of the organization's mission wherever I'm giving the lecture. So when I do this at College of Medicine, it's always very focused on healthcare for underserved populations. So racial and ethnic minority populations, queer, trans, and intersex people, people living in rural communities, and older adults, which is a huge emphasis for us. So this idea of healthy aging with chronic disease and healthy aging with CF that I'm so focused on in my work is very relevant specifically for what our students at this medical school are interested in. And certainly CF is a great example to be able to give them, because a lot of them are still learning these very outdated things about CF. So these are the learning objectives on the screen that I set forth for whenever I'm giving this unit in sort of a large group format. And really, it's all about reflection, core values, and the skills that we already have for taking care of people. And that really goes whether you're a clinician or not, honestly. And we also cover some identity and anatomy related vocabulary that can help us have thoughtful conversations in clinical settings. So I'm going to go over some of that because when we were planning this PTF, folks thought it would be really useful for everybody attending the meetings to be able to get an orientation to a little bit of the technical vocabulary, but also then see that more zoomed out focus for the clinical education piece about how do you get clinicians excited, help them feel more engaged, and help them feel less afraid and less disoriented. We know as people living with CF that oftentimes we are this very niche topic rather than folks think of as just being everywhere in healthcare. So it can seem a little daunting working with us, even if that's all that a clinician knows about us. And today's clinicians are coming in with a sense that they need to understand who people are. So let me tell you a little bit about me. I went over the basics. This is just for your reference. One thing I will mention, though, that's been very relevant to how I've been approaching developing this chapter is that I am a survivor of intimate partner abuse. A lot of you hear me talk about my wife, who is an absolutely brilliant person I met in my PhD program at FSU. She's a social psychologist, and she is a non-binary trans-sex woman who grew up in North Augusta, South Carolina, and had, I will say, a very different childhood than I did. I grew up with two other people who were various locations within the non-binary landscape and who really encouraged me to be myself. Growing up also, my mother's family's Tuscarora acculturation, being non-binary wasn't unusual in Tuscarora society. It was considered to be very normal. And this is the case for a lot of Indigenous American societies. So I'm presenting today from really the heart of the Seminole territory in Florida, which is not too far from the Creek Nations territory, a little bit farther west along the Gulf Coast. And then the Tuscarora people were a small tribe in the eastern North Carolina lowlands. So, being non-binary is something that you see, in a lot of societies around the world as just part of the general social fabric. This is narrated in different ways in different Indigenous American communities and nations. You may have heard the idea, for example, of being two-spirit. That is one of the ways that non-binariness can show up in everyday life. It's not the only way. And so it really was the outside world beyond my home that exposed me to the idea that people would think that it was bad that I was non-binary, or that it was bad to be part of the trans community. My wife had a very opposite experience growing up. And so, our perspectives coming together as people who have both survived abuse. I was in an abusive marriage with a man before I was married to my wife. And that taught me a lot because it really implicated my sex, gender, and sexuality in some specific ways. And that wove together with the healthcare that I was getting and what I thought I should be advocating for myself about during those times in my life. So all those lived experiences really shape the consciousness that I bring to teaching. So I tell students a little bit about myself, and then I ask, well, okay, think about you, and then come back to this question of why you want to be a healthcare provider. And I'll note that some students, this is the first time that they're really hearing in detail about the fact that gender and sex are different. Those are different aspects of who we are, and we'll go over that in just a minute. So I am an agender person in terms of my gender. I don't have a specific gender identity. That's one of many types of non-binary gender identities. Agender people are totally outside the gender binary. But I'm also female. I was assigned female at birth. When I was born, doctors said, this kid is female. And as far as I'm aware, they got that right. I have never felt that I was anything other than female. And I have never seen evidence that I have substantial anatomical or physiological characteristics of maleness. But these sets of characteristics aren't mutually exclusive. Just like you can have introversion and extroversion at the same time, you can have maleness and femaleness at the same time, and many people do. So I ask students, what do you think the population prevalence of having intersex characteristics is? And there are different estimates. So depending on how you define being intersex, we'll talk about that. It can be anywhere from about one in a couple hundred people to 1 in a couple thousand. I've heard estimates of everything from 1 in 100 to 1 in 4,000, depending on how we define intersex characteristics, how strictly or loosely. And people may wonder, well, am I really, maybe I practice in a small community. Am I really going to meet intersex people? Well, I ask them, gosh, what do you think the population incidence in the US of cystic fibrosis is? Every once in a while, I get somebody who knows that statistic. Right now, it's about 1 in every 20,000 live births is a person with CF. That is at a minimum 5 times less common than being intersex. But realistically, it is way less common. And then students are like, oh yeah, because they're meeting me, right? Like they met a person with CF. So when clinicians meet me, they get a more expansive sense of all the people they might meet while providing healthcare. And that's all the people they would want to be ready to respond to in an inclusive way. So that's really the focus of everything else that I do in this unit, is just this expansive thinking about how do we make that space for people to be who they are and need what they need. So in sexual and reproductive healthcare, this has nuances, right? We talked about abuse. Feminized people of every sex, gender, and sexuality are marginalized in healthcare to begin with. We are infantilized. We are treated like naive little girls who don't know what's good for us. If you know the history about hysteria and why we still call the removal of the uterus a hysterectomy, you know a little bit about how that has played out in society over time. But it also creates opportunities. Clinicians are in positions of power and can use that power and privilege to create affirming, welcoming spaces that change the story. A lot of folks get socialized to think that this is really hard to do. And if you ever get anything wrong or mess it up, people are going to bring the fire down on you and you're going to lose your job and get dragged on Twitter. And people have a lot of anxiety about this. And none of that could be more wrong. Because what affirmation is really about is about communicating that whatever a person might want to share with you, whatever a person might want to feel welcome for, you value that and you're going to do your best for them. And this is important, irrespective of the specific sex, gender, and sexuality characteristics that a given person has. It also helps you do a great job in advancing in your clinical education milestones. The step 1 exam that all students training for an MD degree, for example, take after their second year has a content unit called preferred form of address. You got to be able to demonstrate that you've mastered this clinical skill in order to be able to advance in your education. So drawing that connection of, asking about pronouns or sharing things about you that invite other people to share about them, that helps you make sure that you're always incorporating preferred form of address in an encounter. So you'll see that woven throughout this chapter, of some different clinical skills that can help get people comfortable with sharing. So here, I give a little rundown of how sex and gender differ. Sex and gender are both identities, and both of them have many moving parts. Sex is more about how we relate to our bodies. Gender is more about the social roles we occupy and how those get interpreted in relation to our bodies. So think of sex as being closer to the body than gender is. It's like a degrees of separation question. And sex and gender are very interrelated because people we meet often assign gender roles to us based on what they think our sex is. There is a great graphic that I really love that's part of a big toolkit on trans student educational resources, which is a wonderful website. I am going to put the link for that in the, actually, if you just Google trans student educational resources, you'll get their most current material. Wonderful learning resources. There's also, one of their links is here on the slide, if that's an accessible format for you. But I also have a link to TSDR in the previous slide if you are working with the PowerPoint yourself and you just want to pull that up. This gender unicorn graphic illustrates how different aspects of who we are go together. So you can see up at the top, you can have different elements of gender identity that may be narrated different ways in different cultures. So in American English, female, male, and intersex are sex terms. You can see that down here with sex assigned at birth in the middle. Some cultures don't distinguish between female and woman, for example, the same way. And so this is written expansively to make space for that. In American English, usually when we're talking about gender, we're talking about characteristics of being a man, characteristics of being a woman, and characteristics of being other things. So I really like the way this graphic makes space for that. There's also information about attractions, physically and emotionally. These are all part of your sexualities. Sexualities are very expansive, and that may be the longest section of the chapter because there's so much that falls under the umbrella of how we relate to each other and to ourselves, sexually, and also in ways that intersect with sex, like romance. So I love the unicorn. The unicorn is great. And it was designed by trans people. It was actually designed by a bunch of different trans people of different racial, cultural backgrounds, different sexualities. And it really represents the inclusive spirit of our community. We love the unicorn so much that my slide is refusing to advance. Oh, there we go. Okay. But what about body parts? So a lot of clinicians are thinking, okay, great, all this vocabulary is super helpful, but don't body parts also matter? Oh, they for sure matter. And I think as people with CF, we understand that well. Our anatomy is often unique because it's impacted by our disease. So the portions of the chapter that talk about anatomy go into detail about how our sexual anatomy may be unique in ways that involve our CF and also implicate different identities like sex, like gender, like sexuality. So a great clinical skill, and we cover this in the chapter, is the organ inventory. In the CF community, we know why this is important, right? We lose pieces of ourselves. Sometimes they get replaced, sometimes they don't. This concept is really powerful in sexual and reproductive care for people with CF, so we go into that in detail. Also, the idea of the check multiple list, very powerful. Letting people choose all the characteristics out of a list that apply to them. So if you're asking about sex, for example, are you female, intersex, male? Check all that apply, because those things can go together. Easy skill to implement, really easy. Lets you get it right from the get-go. Then we've got a vocabulary slide, and I'm going to encourage you to explore on your own with a copy of the PowerPoint using the notes that are included in the non-presentation view. So that's what's below the slide that the person who created the slide can mark up. It's a big field of just standard text. So the idea of being transgender, where your gender identity is somehow different than what people expect from you in your society, or cisgender, which means that it's not. The idea of being transsex or cissex, same deal. So does your sex match what you were assigned at birth or not? And being intersex, where you have mixed sex characteristics, or endosex, where you only have characteristics of femaleness or maleness. There's lots of little nuanced technical vocabulary about specific identities people may have. that can be helpful to know. But the most important thing here is the own voice of the person themselves. We come back to the idea that gender conscious care is much less about technical expertise. The same way that CF is so vast and that sexual and reproductive healthcare are so vast. You can't know everything about us just from meeting one of us. You can't even know everything about one of us just from meeting one of us. So the key is to make space, to think expansively, to think when you're working with trans people, for example, about everything our healthcare might include, rather than thinking, oh, I'm going to need to be most focused on this person taking hormones or getting surgery because they want to, quote, transition. A lot of people in the trans community have absolutely no interest in that. And as a person managing CF who happens to be non-binary, I take hormones. Those hormones don't have a lick to do with my gender identity or expression. I take them for two reasons. Number one, to help thin out the mucus in my reproductive system. And number two, to protect my bones from becoming Swiss cheese from the steroids that I take to protect the tissue in my lungs. So, trans person taking hormones, the one does not have a thing to do with the other. So asking questions rather than making assumptions is key. And in your breakouts, Eliza and Katie are going to be working with you on developing questions that we're going to suggest that providers ask patients and that patients ask providers. And if you've been with CFReSH before, you know how this works. We've got some questions already woven into the text of the main text of the chapter narrative, but we'll also have some breakout content about things to know and ask. And then finally, we kind of come back to this idea of bias and the fact that we all have biases. I am absolutely sure that some of you come into this meeting today were a little panicked about screwing up pronouns or feeling like you were unfamiliar with a particular concept, being out of your depth, or realizing, wait a minute, I might have been inadvertently reproducing prejudice. Guess what? That's universal. You're human. It's okay. Everybody grew up with biases, prejudices, preconceived notions. That's literally what prejudice means. That is part of the human condition. The key is to see it, acknowledge it, and challenge it actively every day. If you feel a little bit out of your depth or like you're learning new stuff, you're doing it right. And if you watched the Beam stream yesterday, you saw me talk about the fact that hot shots kill people. People who think they know everything and want to act like you shouldn't get a word in edgewise to advocate for yourself, which if I made a Venn diagram of people who have those characteristics and SRH providers, especially older white male ones, yeah, that's going to get close to being a circle. So instead, being creative, being humble, letting ourselves be human, because guess what? When your patients have space to be human, if you're a clinician, you have space to be human too. And that is potent. So I cover some examples of biases, and we could all probably go around the table and think about myths that we've heard about trans people, about queer people, about intersex people, about people with CF, whether or not anybody's part of any of these other communities. Sandy put an excellent comment in the chat saying that's called cultural humility in med school talk. Absolutely, absolutely. We often also use the term openness at our medical school, just a way that we create opportunities to be human together with our patients and to have that humble spirit of doing teamwork together. That's how you be a hero for us. And I think as people with CF, we know well the absolutely electric power of the first time a clinician really listened to us. So these are just a few examples. When I do this unit with clinical learners, I also give them stories about different patients, like little vignettes that they actually deconstruct in small group as case examples. And there are no right answers. It's just different stories that bring different chronic conditions, sex, gender, and sexualities, and lived experiences of oppression together in different ways that stimulate creativity and thinking. Well, gosh, what questions would we want to ask these patients? And what questions would we want these folks to feel comfortable asking us? This slide, honestly, I could deliver it in a module about CF without changing a thing. We get hurt so much in our care because people don't listen to us, because they don't understand our condition, and because people infantilize us. So as a result, we may be recalcitrant about coming forward and advocating for ourselves or getting the care that we need. Not surprisingly, this entrenches the disparities that affect us. And for intersectionally marginalized people in the CF community, whether we're queer, trans, or intersex, whether we are of racial and ethnic minority backgrounds, whether we are cross-disabled, whether we are on the spectrum, these disparities just get exponentially more dramatic. So I always wrap up with students bringing it back to core values and the idea that good healthcare involves getting comfortable with being uncomfortable. It's okay to be confused. It's okay to feel disoriented. It's okay to worry about whether you're good enough. Because guess what? We worry too. And we know that you're trying. Oftentimes, when somebody gets a pronoun wrong, they panic and fall over themselves apologizing. That is the last thing you want to do, because guess what? You're human. I can tell you how many times a day somebody mispronounces my last name. Correct it and move on. Just show me that you value knowing who I am. And let me tell you, it is all kinds of awkward if somebody has got like their hand in your vagina and they get their pronouns wrong and then they try to like make you manage their feelings apologizing. It's like, no, blue screen of death. Like, don't, please, let's please continue feeling my vagina. Tell me if I have any polyps. We don't need to have a big involved conversation about this. Instead, show me you've got a curious mind, a kind heart, and that you're aware of my context. And I tell students, and I'm going to tell all of you, look, being here today means that you care about these things and that you're building your skills in this area. So I tell them what they're going to do in small group, which is what we just talked about with this vignettes. Be creative, think expansively, be bold in imagining what kinds of healthcare services might a person with CF need in your sexual and reproductive health care setting. What questions do you want to ask us, and what comfortable things do you want them to come forward and ask you? Think about what you want the encounter to look like and how that reflects the values that led you to become a clinician in the first place. Think about how exploring your biases is going to make you a better clinician. That is what professionalism really means. It's not about making yourself look as much as possible like the good old boys who've tried to shut you out. It's about welcoming people in. And then finally, I give them my contact information, encourage them to connect with me on social media if they're not already, and conclude with the fact that in order to make space for us, you've got to meet us. You've got to know we're there. You've got to see us, and you've got to open yourself to really learning from us, not just in the clinic, but in life. Because 99% of our sexual and reproductive wellness management doesn't happen in the clinic. It happens at home by our own hand and is deeply shaped by the trust that you cultivate with us. As people with CF, we are literally putting our lives in the hands of others. That's not something to be done lightly, and it's harder to do when we experience intersecting forms of oppression. But that also means that the joy when a provider does really center building that trust with us is absolutely boundless. And it's transformational. I see that Eliza has put in the chat that in Buddhism, that openness and humility of welcoming in everything we might learn about others and ourselves is called the beginner's mind. So my advice, and you'll see this in the chapter, is that clinicians and anybody else who's participating in healthcare, never lose that. Be an eternal student of life. Be an eternal champion of what you don't know. That's what affirmation really means. So I'm seeing some cheers in the chat for the idea of beginner's mind. Sandy, I love that. Sandy's team has termed this affective curiosity. I may borrow that with attribution. I love that. And then, oh goodness, Kristen has put a wonderful comment in the chat. Zan, this is entirely off topic for our discussion, but I struggle with how children's books present gender. Skirt equals girl, pants equals, well, it could be pants equals boy or girl. Interested if you have any resources. Go to Trans Student Educational Resources. They've got wonderful ideas. Also, we cover this in the chapter, that environment that you create with the decorations in a clinic, the pamphlets, the kind of people you see on the walls or in educational materials. Can you see yourself there? Yes. And that's why meeting people in different contexts is also important. So a lot of time when I'm working, I like to wear like a dress and a jacket and stockings. It's not because that's a gender thing for me. It's just because I think it looks cool. And that's kind of like a lot of the time that's my work look, or I might wear like some cigarette pants and a blouse or something like that. But when I'm not working, a lot of the time it's like a dock worker. I'm wearing like ripped up jeans and combat boots and a big puffy vest or something like that. And none of that's a gender thing for me. It's just fashion. You know, I'm not ever thinking about, am I authentically presenting my gendered self? Because I don't have a gendered self. I have you know how some people don't have an appendix or don't have a spleen or didn't have wisdom teeth when they were growing up? I just don't have that thing. So, but that's not universal for everybody. And I tell you, like, especially my wife, when she's in care settings that are supposed to be for women and females, and it's very clear that she's not welcome, that's tough. And we have quite a few very openly trans-sex people in the CF community who really struggle to feel like there is space. There's also not much literature right now on if you do want transition, if you want hormones, surgery, anything like that, what does that look like for people with CF? So that's one of the reasons why we were so expansive with how we're marketing these meetings is if OBGYN or other SRH care has ever been relevant for you, we want to hear from you. Could mean you're assigned female at birth, might not. It might mean you're female now, but doctors didn't think you were female when you were born. It might mean something else. So we tried to be sensitive to that. So Sandy's put some more information on the chat. Yeah, the framing of colors, right? Like, why do we decide that certain colors are for certain things? And the pink and blue have actually flipped many times throughout history in this society about what's for girls and what's for boys, you know? And you see, I use like different pink and blue and purple colors in this slide presentation because I want to get people thinking about, well, gosh, why do we even think of colors as being gendered? They're also the trans and bisexual flags colors. I don't know if you can see my flair, but I wear a lot of swag when I do this unit that has, you know, like my bi flag pin, my they them pin, my probably got my my rainbow flag Florida pin up here, you know. So I like to have some swag that's, you know, that's colorful, that makes people think about pride.